This is my first EDS conference attendance, so thank you everybody for coming out. Thank you for inviting me, and I'm very excited to give this talk to you, so I appreciate your attention. And I have to start off with an apology. I ended up making some pretty significant changes to the PowerPoint a little bit late. I have forwarded that to the admin team, so you guys will get access to that from the PDF perspective so that you can follow along. So I apologize if that original version make that a little bit more cumbersome, but I will submit that so that you guys can have access to it. And for the pictures, it was originally a video, so I do have videos of all the taping techniques and the assessment pieces, so if anybody wants to find me afterwards, I'm happy to show those to you guys. Sometimes the videos are a little bit easier to get a sense of than the pictures, but without further ado. So I have no disclosures. We'll be discussing relevant anatomy and research, discussing promotion of strengthening and using external mechanisms for stability of the knee, and talk about some things that you can do for yourself or your patients or your client management starting Monday. The original study that got me started looking at a lot of this was looking at the morphology of the skeletal muscle tissue. So I found pretty interesting. It's a little bit older, from 2017, but the premise of the study was that we know that we have different types of collagen in the body, and when that genetic coding and gene expression works very well, we have a normal, nice tissue quality. However, we know with EDS, generally speaking, there are some known and unknown mutations in that gene expression that can affect our connective tissues integrity-wise. And the example that they give is with type 6 collagen. We have genetic errors in that type 6 collagen that can manifest itself in patients as a myopathy or a muscular dystrophy, and they use Ulrich's dystrophy specifically, citing as an example. And so with that, you have a physical deformity in the skeletal muscle. But we know there are different types of collagen. So this particular group looked at studying primarily classical EDS in their criteria, and with known type 5 collagen errors manifesting itself in the skin and the joint especially, they wanted to know if there were any differences in molecular signaling, protein synthesis, or if the actual morphology of the muscle was affected as it might be in type 6. So we know that with classical and hypermobile types, there is a reduction in tendon stiffness as compared to a healthy population, but there was no studies up to this point looking at the physical skeletal muscle tissue. So they looked at protein synthesis and skeletal muscle morphology. This was a pretty small study because it was so early. They have 10 age and sex-matched healthy controls, and they compared that to 13 classical EDS patients and 3 vascular EDS patients. They utilized a whole body DEXA scan and an MRI to look at cross-sectional area and muscle fiber type. They also looked at a biopsy of the vastus lateralis to compare the physical skeletal muscle morphology. And they also looked at protein synthesis rate via blood work. And so ultimately what they found was a surprisingly normal morphology, gene expression, and protein synthesis. And one of the other outcomes they compared this with was a fatigue subscale. So they used the checklist of individual strength, and they had the controls and the EDS group fill out the fatigue inventory specifically. And what they also found secondarily was that all of the hypermobile group reported fatigue ability, whereas the control groups did not report any fatigue. And despite that, having similar cross-sectional area of the muscle fibers, lean mass fiber type, so type 1 our aerobic musculature versus type 2 being our powerful type, and protein and collagen synthesis being unchanged. So they contributed that there was no significant muscular morphology that would also explain the fatigue ability report. So ultimately, there are different genetic changes in different types of collagen, but those may manifest themselves differently in the skeletal muscle. Vascular EDS patients tended to demonstrate more type 3 collagen, which is going to affect the flexibility of the tissue and the elasticity. And The vascular EDS as compared to the classic EDS also had more remodeling in that extracellular matrix, but there's no definitive conclusion on how that may affect recovery in the tissue. One of the more recent systematic reviews wanted to look at how the extracellular matrix deficiencies and tissue elasticity, creating pathologic ranges of motion and accounting for subluxations and dislocations, and that frequency, how that might be affected by different subtypes. So the previous systematic reviews and meta-analyses, the studies did not include those clinical analogs and the subtypes of EDS in their analysis, given that we changed the criteria for that back in 2017. They also wanted to report on exercise studies of the methodologic quality and the quality of the exercises that were given in those studies. And further, they wanted to utilize appraisal tools and reporting guidelines to really grade those exercise studies. So we'll talk about a couple of those. The first one being by Farrell. They utilized closed chain exercises in their study. It consisted of 3 exercises initially, being a body weight squat, a plie, and a bridge. So for the first week, they did 1 set of 5 reps every other day, and at week 2, they transitioned to 2 sets of 5 repetitions. On the 3rd week, they added a forward lunge with 1 set of 5 reps, and week 4, 2 sets of 5 reps. In the 5th week, they transitioned to 1 set of 10 for every exercise. In the 6th week, 2 sets of 10 for every exercise. In the 7th week, they added a lateral lunge with 1 set of 15 reps for all exercises, and week 8 with 2 sets of 15 reps for all exercises. So after the 8th week of the study was complete, they went back to look at their strengthening specifically, and they utilized the patient into a chair where the patient is seat belted, and they have handles that they can grab onto, to where they use a machine that where the leg is fixed, the leg is only allowed to move at a certain speed for kicking out and pulling back, which would allow them to assess the torque and the strength of the quadriceps and the hamstrings specifically. So no matter how hard they push, the machine will only move at a certain rate of speed. This is commonly used in a lot of muscle strength testing because it's very specific and the computer is recording those. So what they found was what they describe as moderate or modest but significant improvements in the strength using that as a testing tool. Another study that was included that they highlighted specific to shoulder strength, which is beyond the scope of the knee emphasis certainly, but what I want you to pay attention to is the protocol that they used more specifically. So we know that mechanical loading is known to increase muscle strength and tendon stiffness, and certainly seems to be important for the talks of what we've had today and what we've learned this weekend so far. So I don't want you to get too bogged down. I know there's a lot going on with this, and I'll include this in the supplementary materials. What I want you to notice is that there's a very specific set of criteria that they use in terms of grading what percent repetition of a max that they're using is and how they increased the sets and reps over time. So if you look at that first row where they have X1, that corresponds to how much load they use. So how heavy was the load were they trying to target? And the second column, X2, that's the number of repetitions that they did. X3 is the number of sets. And so you can get an idea for how they increased the number of sets but decreased the number of sets because they were using a progressively heavier weight. So that's going to highlight progressive resistive overload, which is very important for promoting strength in our patients' clients. And again, I'll put the whole table in there so that you can see what the remainder of the values are, but just appreciate the rate and the grade that they use for the loading. These are the specific examples that they used, and I included this because they performed all open chain exercise, so meaning that the hand was free to move, whereas the previous exercise used the weight going through the legs specifically. So ultimately, they demonstrated improvements in some of the testing criteria that they would use to diagnose a certain amount of laxity in the shoulder. So this has to do with how far does the shoulder move out, how far does it move in, how flexible is the joint itself, and they found some improvements in what that looks like in terms of clinical assessment. So then I thought to myself, that seems pretty traditional, like what most orthopedically oriented physical therapists would give to pretty much anyone that needs general strength and conditioning. So then my thought was, well, then why doesn't that work for everyone? So I think there's certainly more to it than just with that, what that shows. But they did demonstrate ultimately that there is an improvement in strength in individuals with hypermobility. The third study is in here for completeness. They used 3 in the article, but it's a little bit farther afield from what we're focusing on for this talk. And then a more recent randomized control trial was back in 21. This was specific to the knee, so we'll talk a little bit about what they did to promote strengthening. Their ultimate goal was to increase muscle mass and strength of the legs and the trunk. So they utilized 2 sessions a week over a period of 12 weeks and about 50 minutes per session on average. So they started their initial session to determine what a 25 rep maximum would be for a patient. So all of these exercises were done in a gym style setting, and we'll go over those specifically. But they asked the patient to perform a number of repetitions that they could do no more than 25 reps to give them a place to start. And they reassessed their numbers again at the 3rd session, but this time was to determine a 10 rep maximum. That way they could work off of to increase their weights. The 6th session was guided by a physical therapist, but beyond that, most of the sessions were independently performed. And these are some examples of the exercises that they did. So we have a single leg shuttle press, single leg knee extension, single leg hamstring curl, bilateral hip abduction, single leg calf raises, and we did some lumbar extension and some lumbar or trunk flexion rather. So the first 2 weeks again were set at 2 sets of 25 with a low percentage of 1 rep maximum. So if we look at the Holton curve in the bottom right, is more widely accepted for different percentages of loading depending on what you want to target in the tissue. So for example, with strength we might do closer to 4 repetitions, and endurance we might do closer to 25 repetitions. But the authors surmise that doing a lower set the first 2 weeks will help the patients get acclimated into the equipment, get the tissue conditioning before starting doing heavier loading with these particular patients. So beyond the 10 weeks, they targeted an 80% of a 1 rep max, which they use a formula to calculate based on what the patient was able to perform with their sets and reps. So they asked them to do 3 sets of 12, and if the patient was able to do more than 12, then they asked them to increase the amount of weight that they used in the program. So the knee strength was measured in a similar way as we discussed before, but this time the difference is that the leg didn't actually move through a range of motion. The leg was fixed, so they would just push or pull into the unit that would measure how hard that they could push. So it worked a little bit differently, but the same idea, trying to isolate the knee as much as possible. So initially the resistance on the leg press was 57 pounds, and at the end of the last session, the average for everybody was around 112. So pretty significant differences in averages, but despite this, there were no significant improvements in muscle strength. So some of the explanations were that they used a static test instead of a dynamic test, and the dynamic improvements might be small, albeit going from 57 to 112 pounds seems like a pretty significant increase. But importantly, only 8 of the 27 participants used more than their own body weight in a single leg press, so there was some question about could more gains be had if they were to continue a little bit longer. And one interesting point is that on the 6th visit, which was the last supervised visit by the therapist, there were many participants that didn't increase their resistance beyond what they had that day. So they spent about half of the program not increasing even beyond that point, which I thought was interesting. They also surmised if 2 sessions per week would be enough to develop some improvement. Enough of the science-y stuff. Let's get to some practical application. So we'll talk about some stability through external mechanisms, and specifically I'll focus on taping for this portion. And bracing, of course, gets an honorable mention. And what I think about with bracing would be if someone's internal anatomy is not able to withstand what they need to be able to do on a daily routine, I want to think about things related to if something's being tensioned too much. So do they have a quadriceps strain or a hamstring strain, or is something being compressed, or do they have swelling and pressure, or do they have too much sliding? So if the kneecap is moving too much within the joint itself, is there something I can do to help offload some of that stress? So this is an example of a way that I might test it. So I would just do a traditional step up where I have the patient to place the target leg on the step, and I'll have them work back and forth off of the step. And I will use my thumb at the outside part of the kneecap, and I'll actually move the kneecap towards the medial direction, trying to change the way that's moving statically or dynamically while the patient moves. And if they have an improvement in symptoms, or if it feels easier to do, or if it's just more comfortable, to me that would be an indication to try some taping, something that we can do pretty quickly and easily in the clinic. So this is an example of using leukotape. So if you're not familiar with leukotape, it's very rigid and very firm. It doesn't flex a whole lot. So if someone needs a little bit more pressure, I might start with this and assess how that goes. If there's somebody that needs less pressure, usually we can get away with a flexible tape like a kinesio tape. So with, and this, I do have videos again, so if you want to come find me afterwards, I can show you the whole video and the breakdown. But this demonstrates the direction and how I might pull the leukotape to try to get that same sense of pressure from my fingertips. And the kinesio tape is done exactly the same way, just with a different tape. And usually the kinesio tape is more comfortable on the skin, so we don't have to use coverall, but you could if the skin is more sensitive. And then just because I'm a little bit short on time, we'll skip the knee extension component. But again, I have videos of this as well, and it just goes through how you can use the kinesio tape to stop the knee from moving back too far and give the patient their own cues of when they're moving too far, and then how you can challenge that using external resistance like a band or a pulley, as in this case. And I find that that tends to help anecdotally. And then I'll reserve the rest of my time for other clients. Thank you.